going to record now. Okay. So today we have Dr. Claudia Novak. She's a pathologist at Toronto General Hospital. She has interest in pancreatic cancer transplant pathology, autopsy, gastrointestinal pathology, and medical education. She's an assistant professor at the University of Toronto and created an innovative 2-week boot camp to bridge the gap between lectures and clinical practice for students. Dr. Novak recently won the Early Career Teaching Award at the University of Toronto. So thank you so much, Dr. Novak, for being here today. We're so happy to have you, and I will pass it over to you.
Hi, everyone. Thank you for having me. So let me just share my screen and we'll get started. Okay, is everyone able to see my screen? As mentioned, I'm a GI pancreas pathologist at Toronto General at UHN, and I'm very lucky to be here. So thank you for inviting me, and hopefully we'll be able to answer your questions. So just to clarify, I am a pathologist and I will not be able to answer any treatment-related questions. So today we will focus on the pathology report, and particular pancreatic ductal adenocarcinomas. However, we will briefly discuss neuroendocrine tumors at the end as well. So the purpose of this talk is to understand the pathology workflow and understand the pathology report. Sometimes I know that my clinical colleagues get the pathology report and they're like, what does this mean? So it must be difficult for everyone to understand at times. So this is the purpose of this talk, just to understand what we mean in our reports. So just to begin with, we're going to talk about the pancreas. So as you all know, the pancreas is an abdominal organ. It is located below the diaphragm. It's exocrine and endocrine. So endocrine is where the neuroendocrine tumors develop. It's associated with insulin. The endocrine component is associated with the islets of Langerhans, which are responsible for insulin, glucagon, somatostatin, and PP production, whereas the exocrine component is associated with the ducts. So like all these little ducts that flow into our bowels, and this is associated with pancreatic adenocarcinoma. So this is what a normal pancreas looks like under H&E or under my microscope. So we have blood vessels, we have ducts, we have acini, which produce all the digestive enzymes. And then we have our islets of Langerhans, which are the endocrine organs. And this is where neuroendocrine tumors arise from. And then we have our interlobular ducts, and this is usually where pancreatic ductal adenocarcinoma arises from. So let's start from the beginning. Usually a patient presents with symptoms. They undergo diagnostic procedures, whether it's radiology and a biopsy. Within the biopsy, I get to see the biopsy under my microscope, and I let the clinicians know what I see. If it is a tumor, then it is resected usually by the surgeon. At this time, there is an option for biobanking, where the surgeon takes a fragment of the tissue and submits it to biobank, and then it undergoes genetic testing and research. Once the specimen is resected by the surgeon, it goes to the pathology lab where it is grossed. Grossing means a visual inspection of the specimen by our pathology assistants. Then the specimen is processed, evaluated by the pathologist, and then a report is generated, which goes back to the surgeon and oncologist. So this is an example of the types of surgeries that you can have. So this is a Whipple's procedure. So where the pancreas and part of the stomach right here, pancreas, the head of the pancreas is removed, and part of the duodenum is removed, and the gallbladder. But there's other procedures that you can have. You can have a distal pancreatectomy, which means the tail of the pancreas is removed. A total pancreatectomy, which means all of this is removed, so all of the pancreas, or enucleation, where it means they scoop out the tumor. And this is what we see in pathology. So once the surgeon resects the specimen, this is what comes out. This is an example of a Whipple specimen. So it's a partial duodenectomy, partial pancreatectomy with duodenectomy and gastrectomy. We have the gallbladder, we have our stomach, and then we have our duodenum, and then we have our pancreas. So remember when I said when the tumor comes out, it's inspected by our pathologist assistants or our PAs? Well, this is what they see. So our PAs do the visual assessment. So they measure the size of the tumor. They ink the margins. So an margin is defined by where the surgeon makes the cut. In a Whipple specimen, there's a couple of margins. So there's the cut where the stomach is made, where the stomach is. And then there's the duodenum. There's the uncinate margin, which is on the back side of the pancreas, and the pancreatic neck or parenchymal margin. Lymph nodes. So lymph nodes are our immune organs. They usually surround the pancreas. That means they're regional. But if they're further away from the pancreas, that means they're distal and they're non-regional. And then they also talk about the extent of invasion. So what the tumor is involving. So for instance, if we have a tumor here, is it involving the uncinate margin, or is it involving a portion of the stomach or the gallbladder, or is it adheres to the duodenum? And then they also sample the specimen. So they pick out what sections we see under the microscope. So once we have our specimen grossed by the PA, so that's this part, including fixation, and undergoes a cycle. So it undergoes processing, embedding, cutting, staining, and then microscopy. And this is what we see under the microscope. So this is a cute little video that I got from one of the surgeons, and this is what I think they think of us as pathologists. We're usually cited to be very introverted, but don't be afraid to approach us. We're more than happy to discuss your pathology report. And then we use our microscope to evaluate the slides. So the purpose of the pathology report is the evaluation of the glass slide resulting in the pathology report and making sure the gross description correlates with the imaging, so the radiology report, as well as what the surgeon saw at the time of the OR. So the pathology report. So the purpose of a pathology report is to summarize the relevant histological findings that will guide treatment. So this includes histological subtype and grade, so whether it's a neuroendocrine tumor or whether it's a PDAC. Tumor staging, so in pancreas, for pancreatic ductal adenocarcinomas that involve size, whereas in pancreatic neuroendocrine tumors that involves the proliferative rate. We'll talk about that more later. Also, the amount of lymph nodes involved, which will impact lymph node staging. Microscopic evaluation of the margins. Remember, that's where the surgeon made their cuts. Any additional findings, as well as additional IHC, biomarkers, and molecular. So these are the components of a pathology report. We have the demographics, so the patient's name, date of birth, their address, as well as the referring surgeon, any additional clinicians that need to be involved, and so on. The diagnosis, the synoptic data, the gross description generated by our pathology assistants, and plus or minus a microscopic description or comment. So today we will focus on diagnosis as well as synoptic data. So let's talk about diagnosis. And we'll begin with pancreatic biopsies. So a pancreatic biopsy is done when the patient begins to be symptomatic, and on radiology, they identify a mass or a lesion. And they'll usually use a needle to biopsy a specimen. And this is basically what a biopsy of a pancreatic core looks like. This is tumor. This is a pancreatic ductal adenocarcinoma. So biopsies have three potential diagnoses. It's an adenocarcinoma, it's negative for adenocarcinoma, or I'm not too sure. So the adenocarcinomas are usually pretty straightforward. Pancreas is notoriously challenging to diagnose on biopsies, just because not a lot of people see it. And in these situations, sometimes it's due to like the amount of inflammation present because of chronic or acute pancreatitis. It can be very challenging. So we usually recommend additional biopsies if we see atypical epithelium or cells present. And then for a non-diagnostic pancreas biopsy, we just say that these findings may not be representative, especially if there's like a cystic lesion, like an IPMN, where it's hard to actually get epithelium. So we'll recommend another additional biopsy. Okay, so let's talk about examples of a diagnosis in a resection specimen. So we'll usually name what parts of the specimen are present. So the duodenum, the pancreas. This was a pancreas sparing, this was a stomach sparing procedure, so there was no stomach present. We have the grade, so a well-differentiated adenocarcinoma, which is the histological subtype. And the location, so it's involving the pancreatic head. We have the PT stage, so remember its size in pancreatic ductal adenocarcinomas. And then we have whether it's positive or negative for lymphovascular or perineural invasion. We'll talk about what that is a bit later. The amount of lymph nodes involved and the status of the resection margins and whether there's an absence of or presence of high-grade dysplasia or adenocarcinoma. So basically the diagnosis is a summary of what we see in our synoptic data. And our synoptic data are generated by the College of American Pathologists. These are protocols that we use for different types of organs. So there's one for pancreas adenocarcinoma, there's one for pancreas neuroendocrine tumors, which we'll go over later. And there's one for breast, there's one for gynae, such as uterine carcinomas, and there's one for lung as well. So this is a great website to check out. It kind of breaks down what the synoptic data is. So this is basically what is in the synoptic data. We talk about the specimen, so the procedure, the tumor, the site, the histology, grade, extension, treatment effect, if there's neoadjuvant chemoradiation or chemotherapy, lymph presence or absence of lymphovascular invasion, margins, the lymph nodes, distant metastases. So distant metastases means that the tumor is no longer confined to the pancreas or the regional lymph nodes. It has moved past that. So it's either involving the liver or it's involving the lungs. And then any additional findings and special studies. So for pancreatic ductal adenocarcinomas, there's a specific synoptic. It includes pancreatic neuroendocrine carcinomas, which are different from pancreatic neuroendocrine tumors. I will show you the synoptic for pancreatic neuroendocrine tumors later on. And then we talk about the site. So where is it located in the head of the pancreas, which is near the duodenum? Is it located in the body, which is just overlying the aorta, or is it located in the tail near the spleen? And then there's different histological subtypes. So there's ductal adenocarcinoma, colloid carcinoma, signet ring cell, carcinoma associated with an IPMN, etc. ACC is also another histological type, which is a very aggressive tumor. And then there's also other ones such as pancreaticoblastomas, SPNs, which are fairly banal. Okay, so this is an example of a colloid carcinoma. They tend to be a bit less aggressive. They're associated with IPMNs, and they're characterized by these epithelial tumor cells floating in this mucin, pools of mucin. This is an example of an undifferentiated carcinoma. This is a very aggressive form of carcinoma. It basically doesn't look like anything, and it doesn't stain for anything with our immunohistochemistry. So let's talk about grading. When we talk about G1, G2, G3, this is different from the neuroendocrine tumors, which we'll talk about later. G1 means that remember when we talked about the normal architecture and how the ducts look like nice little donuts? Well, G1 looks like a nice little donut, but with a slight bit of differences. G2 looks less like the donut, and then G3 doesn't really look like it anymore. So this is a nice schematic from mypathologyreports.ca from Ottawa of what they mean by histological grade. So remember, this is normal. This is a G1 where most of the tumor cells look like the normal. Moderately differentiated, they start looking less like the normal, but a bit higher percentage. And then poorly differentiated, less than 49% look like the normal glands. And then undifferentiated, it just doesn't look or stain like anything. If anyone has any questions, feel free to ask. I don't have access to the chat at the moment, so if you see any questions pop up, just let me know.
Yeah, no problem.
So again, this is a representation of what a normal duct looks like. And then this is low-grade adenocarcinoma. So remember, it looks kind of like what we see here. And then this is high-grade carcinoma, or a G3, poorly differentiated, and it doesn't really look like anything. So this is an example of a G3 tumor, so a signet ring cell carcinoma. It's called that because it looks like a signet ring. The nucleus is kind of like the gem, and then like this is the ring part, which is filled with mucin, and there's a remaining rim of cytoplasm. Tumors that are not graded are acinar cell carcinomas, so ACCs, acinar cell cyst adenocarcinomas, serous adenocarcinomas, SPNs, neuroendocrine carcinomas. Neuroendocrine tumors are graded, and depending on the grade, that will affect prognosis, but we'll talk about that later. And undifferentiated carcinomas, because they don't look like anything and they don't stain like anything. If someone does receive chemotherapy prior to having surgery, we can grade the response rate. So you'll often see in our synoptic report the treatment effect, where we say either no viable cancer cells present, so the patient has a complete response. Within brackets, I'll usually put in a 0. If there are single cells or rare cells present, that's a 1. Residual cancer with evident tumor regression, but more than single cells, 2. And if there's a lot of cancer, it's a number 3. I think there's someone in the chat.
Yes, there is. Sorry, I was just going to jump in. Just somebody asking, what do you mean by not graded?
Oh, so it means we don't assign a histology grade. So now let's go back here. So remember what we said, we have histological grades for pancreatic adenocarcinomas, and it depends on how well they resemble these guys, the normal ducts. Well, certain tumors, like these guys, like an acinar cell carcinoma, does not come from the ducts. It actually comes from the surrounding acinar cells, which are these guys here, which produce all the enzymes. That's why it's not graded. And then undifferentiated tumors, since they don't stain for anything and they don't look like anything, we can't assign them a grade. SPNs, solid pseudopapillary neoplasms, usually have a really good prognosis. They're very benign, so they're not assigned a grade either. And they usually don't come from the ductal, the ducts. Okay, so we talked about adverse prognostic factors, and we talked about lymphovascular and perineural invasion. So when we say positive for lymphovascular invasion, it means the tumor is in the blood vessels. So once the tumor is in the blood vessels, that means it can spread anywhere in the body. It can go to our regional lymph nodes, or it can go past them to other organs. Perineural invasion, that means the tumor, as we see here, is involving the nerves. And this is a nerve right here. And then let's talk about margins. So margins, like as I said, is where the surgeon made the cut. Sometimes we'll receive a portion of stomach, sometimes we won't if it's pylori sparing. But usually the margins for Whipple's or pancreaticoduodenectomy and gastrectomy are the gastric margin. So this is defined as our proximal margin, our distal resection margin, which is the duodenum, our pancreatic neck margin or the pancreatic parenchymal margin, which is right here, the uncinate margin, which is right here, and then our common bile duct margin, which is our connection to the liver. So recently, there has been great debate whether we call the posterior surface or the anterior surface a margin. So the anterior surface is a surface and it's not considered a margin because there's no dissection involved. It's just resting in the abdomen and can be easily pulled off. Whereas the posterior margin, we found in recent studies that if the tumor is within 1 millimeter of the posterior surface, there's a higher chance of reoccurrence. So although it's not a true margin because the surgeon doesn't need to cut through it, we still report it if there's tumor involving the surface or if it's close because it has an impact on reoccurrence. Also worth mentioning is that if there is tumor within 1 millimeter of any margin within the pancreas, or for pancreatic ductal adenocarcinomas, it is considered positive. That is not true for pancreatic neuroendocrine tumors. We actually have to see tumor at the margin. So when we ink it, we need to see ink on tumor, or there needs to be a cautery artifact on the tumor where the surgeon cut. Okay, so let's talk about PTM end stage. This is probably the most important part for staging a tumor and for determining treatment. So there are different descriptors. So for instance, if it goes in front of the PTM, so P means for pathology, T means tumor, N means nodal involvement, M means metastases. And in front of the PTMN, we can put an M for multiple primary tumors, R if it's a recurrent tumor, and Y for post-treatment. So I've mentioned it before that the PT stage for pancreatic ductal adenocarcinomas is based on size. So if it's less than 2 centimeters, it's a PT1. If it's greater than 2 centimeters, but less than 4, it is a PT2. If it is greater than 4 centimeters, it's a PT3. And if it's involving the celiac axis, it is considered a PT4, irregardless of the tumor size. So the size of the invasive component should be used to determine the PT category. It's a correlation between what we see on the gross description as well as what we can corroborate on the microscopic description. So PT stage is not affected by the extension of the pancreas. So for instance, if the tumor goes beyond the pancreas into the soft tissue, that does not affect stage. If it involves the mesocolon, directly involves the mesocolon, that is not considered, that does not change the stage. It's considered an extension. So anything into the extrapancreatic biliary system. So if the tumor goes up the CBD into the liver, or sorry, if the tumor goes up the CBD, if it involves the duodenum, stomach, spleen, left adrenal, and peritoneum, those are all considered extensions rather than true metastases. So we actually need to see the tumor continuously growing into those organs. If there's discontinuity, that's a different conversation. And if it involves the portal vein, it's still considered an extension and it does not involve It does not change the PT stage. However, it is an independent prognostic factor and it impacts outcomes. So lymph node metastases is an independent adverse prognostic factor. We need to see at least 12 lymph nodes in a Whipple's resection. And the PM end stage is defined no regional lymph node metastases for PN0. If there's 1 to 3 lymph nodes involved by tumor, so that means there's adenocarcinoma present in the lymph node, that means it's a PN1. If there's 4 or more, that's a PN2. So we talked about regional lymph nodes. So those are the lymph nodes or like the lymphoid organs that surround the pancreas. If they're further away from the pancreas and not one of the designated ones that are here, it is considered a distant metastases if there's carcinoma present. So this is a list of the regional lymph nodes surrounding the pancreas. PM is a category for metastatic adenocarcinoma. So metastatic adenocarcinoma, for us to call it distant metastases, we actually have to have the resected specimen present in what we get from the surgeon. So for instance, if radiologically they suspect that there's metastases to the lung, but we don't get the lung, we can't call it a MET. So we often leave that category blank as not applicable or cannot be determined from the specimen submitted. And then additional findings, which are optional, are the pancreatic intraepithelial neoplasias, which is a precursor lesion to pancreatic adenocarcinoma, as well as chronic pancreatitis and acute pancreatitis. So let's talk about the precursor lesion. So we call it PANIN for short. We have to specify the highest grade. So low grade used to be known as PANIN 1 and 2. So this is what normal looks like, and then this is what PANIN 1 or PANIN 2, which is considered low grade dysplasia to look like. Whereas high grade dysplasia or high grade PANIN, formerly known as PANIN 3, looks like this. As we progress from low grade to high grade, you can see how these are nuclei within the cells, how these little round guys, how they become slightly bigger, darker, and then they lose polarity. So that means that they're like all over the cell rather than being oriented at the base of the cell. And as we progress to high grade, they become crinklier and different shapes and sizes, and they're associated with different mutations. We can also perform immunohistochemistry and biomarkers and molecular studies. So molecular studies are done at the request of the oncologist. Biomarkers in Ontario, we currently do reflex MMR for all GI specimens, including the pancreas. So MMR stands for mismatch repair proteins, and it's usually associated with Lynch syndrome. However, not always. That's a very rare occurrence. MMR proteins are usually deficient in tumors that are responsive to PD-L1 agents in the rest of the GI tract. And then I think your oncologists are better equipped to talk about like the potential treatments that you can have with MMR loss. And I think these are some wonderful resources that you can use as patients or as caregivers to understand pathology a bit more, because it is complex. So the CAP cancer protocols, as well as this wonderful website developed by one of my colleagues in Ottawa, and just gives you a breakdown of what the pathology report means. And Johns Hopkins has a really great website where it talks about like the surgeries, the chemo, as well as the pathology report. And don't be afraid to contact your local pathologist, the person that signed out the report. They are the best person equipped to tell you what they mean by certain things that they said in their report. They might not be able to tell you what treatment you will be receiving or what the outcomes will be, but they can definitely explain what they mean by the number of lymph nodes involved and what they mean by the T stage. Okay, so I promised I would talk about neuroendocrine tumors. So let me just pull up the page about neuroendocrine tumors. Are there any questions so far? Okay, so this is the synoptic guideline for neuroendocrine tumors, or endocrine tumors of the pancreas. They are different for pancreatic adenocarcinomas. They are staged differently, they are treated differently. At TGH, they're seen by a different subspecialty, the endocrine team. So these are recommended for any type of pancreatic neuroendocrine tumors involving for patients with pancreatic total pancreatectomies, distal or partial or Whipple's. So let's begin. So it's important to note the clinical history within a neuroendocrine tumor where there is anything syndromic, such as von Hippel-Leyden disease, MEN1, so multiple endocrine neoplasia type 1, and other syndromes. And then when they talk about functional type of neuroendocrine tumors, they are talking about whether there's symptoms associated with the tumor. So whether there's excess insulin secreted, and then they can draw your blood and they determine that there's excess insulin being secreted for a somatic. The patient usually becomes symptomatic and they draw blood, and then they correlate with imaging and they determine it's a functional type of tumor. Then we talk about procedures, so whether it's a biopsy, a Whipple's, so on, and the location of the tumor. So we talked about that as well. And then this is where it differs from pancreatic adenocarcinomas. So a G1 is defined as a well-differentiated neuroendocrine tumor, and it has either a mitotic rate less than 2 mitoses per 2 millimeter squared. So that means mitosis is when the cell divides, and we can see that on our H&E slides, and we basically count a 2 millimeter field squared, and we count how many mitoses there are. If there's less than 2, it's a G1, or if we have a special immunohistochemistry, and if it's less than 3%, then it's a G1. And if it's a G2, that means there's 2 to 20 mitoses in 2 millimeters squared, or it means that there's 3 to 20% Chi67 labeling index. A G3 means that it's greater than 20% for Chi67, or greater than 20 mitoses per 2 millimeters squared. So you can either do mitotic rate or Chi67 to determine the grade of a neuroendocrine tumor. Any questions so far? Okay, I see one in the chat.
Yeah, it says, can a person have a neuroendocrine tumor that can be treated with chemo before Whipple?
I'm actually not too sure about that, and that is actually the best question to be answered by your oncologist. I'm sorry.
No worries.
But usually I think they perform the chemo. Actually, I'll leave it to your oncologist because I don't want to provide you with misinformation. So tumor size will affect the PT stage as it did in adenocarcinomas. However, the most prognostic factor in a neuroendocrine tumor from a pathology aspect is the mitotic rate or the Chi67 labeling index, which will determine the histological grade. So when you see that you have a well-differentiated neuroendocrine tumor and it has a G1, G2, G3, G1 being the best prognosis, G3 is a worse prognosis. This is what they're referring to, mitotic rate versus the MIB1 or Chi67 labeling. And please remember that neuroendocrine carcinomas are different from neuroendocrine tumors. Neuroendocrine carcinomas use the same synoptic as the pancreatic ductal adenocarcinomas, and they are more akin to pancreatic ductal adenocarcinomas than they are to neuroendocrine tumors. It just means that they express neuroendocrine differentiation, but they're really ugly and bad like adenocarcinomas. So tumor focality means whether the tumor is unifocal or there's multiple tumors. The site that it's involved, presence or absence of lymphovascular invasion, perineural invasion, tumor necrosis, margin status we talked about. The margins are the exact same in a neuroendocrine tumor of the pancreas as they would be in a pancreatic adenocarcinoma, except that, remember, in pancreatic ductal adenocarcinomas, the tumor can be within 1 millimeter of the margin to be called positive, whereas in pancreatic neuroendocrine tumors, the tumor needs to have either ink or cautery on them to be called positive. Regional lymph nodes, same as in our pancreatic ductal adenocarcinomas, our distant metastases, and then our PTM stage, remember, multiple recurrent or post-treatment. The staging is very similar to what we saw in pancreatic ductal adenocarcinomas, except that PT3 now is defined as involving the duodenum or common bile duct. Remember, in pancreatic ductal adenocarcinomas, if the pancreatic ductal adenocarcinoma involved the duodenum or the common bile duct, that didn't affect stage. Well, in pancreatic neuroendocrine tumors, it does involve the stage. It does affect the stage, sorry. And then if PT4 is defined as involving adjacent organs, so if it involves the stomach, the spleen, colon, adrenal, or large vessels such as our celiac axis, that's a PT4. PMN category, the number of lymph nodes involved is a bit simpler than it is with PDAC. It is either involved or not involved. And then the PM category, if we have the specimen present, depending on what specimen is involved, we can assign it a PM category. And then additional findings, whether we have acute or chronic pancreatitis, atrophy means like it's the same thing as chronic pancreatitis. So chronic inflammation and atrophy is considered chronic pancreatitis. So adenomatosis, multiple neuroendocrine tumors, but they're less than 5 millimeters. Sorry, another question. I need to see any.
Yes, I have moved to a new city. If I need to see a new oncologist, would it be beneficial to take a copy of my pathology report? Also, how long are frozen sections kept? Are they destroyed once the pathology report is complete?
So yes, bring your pathology report to your new oncologist. That will be critical. So frozen sections. So when we do the frozen sections, it is at the time of the surgery, and we tell the surgeon whether it's there's tumor present or not. And then once that frozen section is finished, and then the entire specimen is in the gross room where the PA is looking at it, that frozen section actually gets put into formalin, and it becomes part of like the entire specimen. So it is, on average, we keep the slides for 10 years. So there should be always a copy of your frozen section slides for at least 10 years. But if you're referring to biobanking, because I know they like to freeze their tissue for genomic analysis, that will be very dependent on the institutional policy. And I would contact your institution if they took samples for biobanking. But if it was a frozen section at a time of surgery, it is incorporated into the specimen, and the slides are usually kept for 10 years. Okay, so adenomatosis means that the tumor is less than 5 millimeters, so we call it an adenomatosis rather than a neuroendocrine tumor. And then what I really like about the CAP synoptics is they have these wonderful explanatory notes, and it not only helps us pathologists as to explain like what a pancreatic neuroendocrine microadenoma is, like less than 0.5 centimeters, what a non-functional tumor is. It also helps, I think, like it might be helpful for patients to read through it and to try to understand like what we mean by histological grade, so that it's very dependent on the proliferative index or the mitotic grade. And this is the most important part for a neuroendocrine tumor. And then this is how we measure the neuroendocrine tumor. And then these are like a little nice table representing what a G1, G2, and G3 well-differentiated neuroendocrine tumor is. Okay, so I think that's my presentation. Any feedback, any questions? So let me just pull up my slide deck again. So when we have pancreatic ductal adenocarcinomas, let me share. They can have different phenotypes. And by phenotype, it means that like we can have different types of epithelium. So the most common one is pancreatic biliary, which is native to the pancreas, but it can differentiate into intestinal type of epithelium, which can produce a lot of mucin. And if there's more than like 50% mucin, that's when they refer to as mucinous adenocarcinoma. The lung can also have mucinous adenocarcinoma. So it's a tricky diagnosis to make. So see right here, this is like pancreatic biliary epithelium. But if we had a bit of like more of these guys in here, but lining the ducts, that would be considered intestinal type. And then if we had like pools of mucin like we do with colloid, but no detached fragments and no IPMN, this is like the white stuff here is the mucin. Couple of questions here. Could you repeat the difference between peanut and a neuroendocrine carcinoma? Sure. So peanut is a well-differentiated neuroendocrine tumor. So remember we talked about the MIB1 or the mitotic rate of a neuroendocrine tumor. So those are usually well differentiated. Grade 1 is less than 3, G2 is 3 to 20%, and then G3 is greater than 20%. Neuroendocrine carcinomas are usually start over 40%. And then if I can just compare the histology, sorry for you. Let me share my screen. Just 1 second. They look different histologically too. So a neuroendocrine tumor has really nice histology. It has like this salt and pepper chromatin, whereas a neuroendocrine carcinoma. Okay, so this is a neuroendocrine tumor. Do you see how nice and like it's kind of organized in comparison to a neuroendocrine carcinoma, which is more a bit more I guess blobby. This is a good picture. So neuroendocrine carcinomas have two types. They have a small cell and they have a large cell. This is an example of a small cell. It's really ugly and it doesn't have a lot of cytoplasm. That's why we call it small cell. Whereas a neuroendocrine tumor, if we look, has really nice nuclei. It has nice salt and pepper nuclei like we see here. So it looks like if you were to dump salt and pepper, that's how we can differentiate it, that it's neuroendocrine tumor, whereas neuroendocrine carcinoma doesn't have that appearance. It behaves more like an adenocarcinoma than a neuroendocrine tumor, and they have different treatment regimens. Also, sometimes it's hard to diagnose a G3 versus a neuroendocrine carcinoma, and there's a whole host of immunohistochemistry that we need to do in order to make the diagnosis. So mentioned that she has been told that she has been stage 2B by one doctor and a stage 3. What is the difference? So these are clinical rather than pathological diagnoses. So I think in our CAP synoptics, they might mention the difference between the clinical diagnoses. You can scroll down. I know what they do for colon. So they don't talk about the clinical differences. So I'm unable to answer that question. I can tell you the difference between a PT2 and a pathological PT2 and a pathological PT3, and that is the difference in size. I assume the difference between a PT2B and a P3 would be the difference in size and what it's involving. So the amount of lymph nodes involved, the tumor stage, and whether there's lymphovascular invasion or perineural invasion. But I think that is best to talk to, if you talk to your oncologist about that, and get them to clarify that with you, because again, I don't want to be misrepresenting anything. Okay. And then mention for a biopsy, how important is it for the tissue sample to be taken from the pancreas versus a distant cancer lymph node? So often the radiologist will biopsy what is most aimable for biopsy. So if it's easier to biopsy a lymph node versus the pancreas itself, they will biopsy the lymph node. And it also depends on what the intent is. So whether this is for a clinical trial, whether they want to add more chemotherapy, whether they want to confirm whether there is a distant metastases or not. So it really depends on what the clinical question is. And what the objective is, whether it's a primary diagnosis of pancreatic cancer, or whether it's to determine for like whether your patient is eligible for clinical trials, or whether they want to confirm a MET. Okay, any other questions?
Okay, that's great. Well, thank you so much, Dr. Novak. That was a wonderful presentation and really informative. I think we all learned a lot. So thank you so much for your time today and for coming out. Really appreciate it. And I'll be sending you an email shortly. Thank you everyone so much for coming out today as well. Really appreciate it.
Thanks everyone for having me. I really appreciate you all coming out. And if you have any feedback on how I can improve my talk, please let me know. I'm more than happy to incorporate it. Thank you.
Thank you.
That's great. And yeah, I'll be sending around a feedback survey just like we do for every support for caregivers. So Dr. Novak, I can definitely let you know what the feedback is. But again, thank you so much, everyone. And thank you so much, Dr. Novak. Wonderful talk. And hope everybody enjoys the rest of your Saturday.